So many of us here tonight will know someone who has had prostate problems or prostate cancer. I'm one of those people. My dad died from prostate cancer in 2001. It was many years before I came to work at St Vincent's, and I believe that if he had been diagnosed now and had access to the kind of treatments that we offer at St Vincent's, rather than living in a small country town, he may very well still be alive today. So tonight's topic is one that's very close to my heart. As Richard mentioned, prostate cancer is the most common form of cancer in Australian males. With greater awareness, new screening procedures and treatments, the disease is now being found earlier and mortality rates are declining. Tonight, our doctors will discuss this disease as well as other prostate-related problems. So to introduce our first specialist, Dr. Raji Kooner is a senior urologist at St Vincent's. He's a robotics, laser and prostate specialist. He performed the first robotic prostatectomy in New South Wales more than 10 years ago, and he's since performed more than 1,200 of these operations. In fact, he's just come from an operation. He was worried he might not be here in time. Raji runs a website, prostatesurgery.com.au, which provides a wealth of resources on these conditions, and some of those we'll be looking at tonight. Next, we have Associate Professor Louise Emmett. She's a nuclear medicine physician with a special interest in the PET imaging of prostate cancer. Louise has initiated radiopharmacy production of PSMA on the St Vincent's campus for evaluation of metastatic prostate cancer. And our third speaker is Dr. Jagavkar. He's a radiation oncologist at St Vincent's with a special interest in prostate cancer. Raj specialises in high dose rates of brachytherapy and seed therapy for this disease. So please welcome Raji, Louise and Raj. And also to say that we will open the floor to questions at the end of tonight's presentation. So, we've heard that prostate cancer is one of the most asymptomatic of all cancers out there. What are some warning signs that we should be looking out for? Anyone answer? Raji?
Yeah. I mean, I think it's one of the dilemmas with prostate cancer, and that's why we encourage people to get tested, because generally by the time patients have symptoms, it's often at quite an advanced stage. But the symptoms that we would normally consider is that if you have voiding difficulties, some hesitancy, pushing, straining to pass urine, that could be due to obstruction from prostate cancer, but sometimes that's from benign enlargement, which is far more common. So certainly if someone had back pain or consistent pain in a region, then you would get that checked as well. But any lower urinary tract symptoms, I think it would be important to get assessed by your primary practitioner initially.
And what age should men start getting tested? Or is it only when they experience symptoms?
There's a lot of controversy in routine testing for prostate cancer, but I think if you want to be proactive and you want to try to decrease the death rate from prostate cancer, I think it's important to do routine screening testing. Ideally, we would say at the age of 50, but there is a lot of work now to say that you can actually get a baseline blood test called a PSA test at the age of 40 or 45, and that can risk stratify you. So if you have a very low PSA, you can then wait 5 years to do it again. So even at the age of 40 or 45, but certainly if there's a family history, you would start early at 40 or 45, but otherwise routinely we'd say 50. And
the first step would be a visit to the GP?
Yeah, I think the main thing would be to see your primary practitioner who coordinates your care and discuss with them your desire to get tested for prostate cancer, and generally the general practitioner would do a blood test and perhaps a digital examination.
Yes, so the digital examination, the dreaded rectal exam, can you explain why that needs to happen when there are other ways of testing for prostate cancer?
So it's not critical for that to happen, but so I don't think if I have patients who are adamant that they don't want to have a digital examination, you can still do a proper assessment. with your blood test and some other imaging tests, which we'll come to. But it's a pretty standard, pretty easy procedure really for patients. I think most patients are quite surprised on how easy it is. It's not very uncomfortable. And the reason we do that is because about 10% of prostate cancers don't produce PSA, the blood test. So if you want to detect those cancers as well, then you do a digital examination. And also if you can feel an abnormality, it generally means it's a more significant cancer that warrants further evaluation. But it literally takes about 5-10 seconds. It's quite easy for patients to get assessed.
So you mentioned PSA levels just then. Can you explain what they are and what it means, for example, if you have an elevated PSA?
Yeah. So PSA is a protein. It's produced by the prostate and it seeps into the bloodstream. The higher the PSA, the higher the risk of prostate cancer. And so if the PSA is elevated, you have an increased risk of prostate cancer. But there are other conditions that make your PSA increase as well. So if you have inflammation or infection, your PSA can go up. Or if you have an enlarged prostate, your PSA can go up. But there are other tests that give us a bit more information. There's a thing called a free to total ratio, because some of the PSA is free floating around. Some of it's bound to another protein. If you measure the free amount of the total amount, you get a percentage, and that risk stratifies a bit better. It gives you a bit more information. There's also some new blood tests that have come out, such as it's called a Phi test, which is a bit more accurate than PSA now. So, and there's a whole lot of genetic testing that's coming out. So I think there'll be ongoing developments in that aspect for detection purposes.
Okay. So Louise, over to you. At what point does a patient come to visit you?
So really people or men come to visit us once they've already been diagnosed with prostate cancer. So very much if Raji has a patient who's going to be having a radical prostatectomy and he needs to know that the cancer is confined just to the prostate, that it hasn't gone anywhere else, and that patient is suitable for surgery, then they'll come and have a scan with us. So what we do is a PET scan. It's called a PSMA PET scan, and we're doing a lot of them on the campus now. The amazing thing about the PSMA PET scans is in 2013, it was actually the first publication in a mouse of a PSMA PET scan, and in 2016 we've now done 1,000 scans at St Vincent's, and we've found it, well, I hope Raji finds it very useful. But I think it has been extremely useful in making sure people are getting appropriate treatment. It's very sensitive at picking up very small volume disease in lymph nodes and distantly, so that if someone's going to be having something like a radical prostatectomy, it's going to work.
Okay, so that's why it's different from previous types of imaging, is that it can...
What it does is we used to do CT scan. MRI we definitely do, and it's very good at evaluating the prostate itself. But traditionally, if you're going to be going for a radical prostatectomy and Raji was concerned that the disease had spread, we would do a bone scan or a CT scan. In fact, I think we have that on the back there. So we've got a bone scan is what we would do quite frequently. And this is the new tracer agent, and this is in a gentleman who's got much more advanced disease than Raji would hopefully ever see before his radical prostatectomies. But what you see there is a bone scan, and it doesn't look too abnormal at all. But when you look at the PSMA PET scan, it is actually concentrating within the cancer cells themselves. And that's what's lighting up on the scan. So that's something that's new. We never had that in prostate cancer. The other PET tracer agents hadn't worked very well. So it's been an exciting journey.
I think Louise is underplaying herself there a bit, because I had patients before that we would fly to Germany to get this scan done, which it originated from, and Louise really initiated the whole program, and we get patients from all over Australia that fly in to have that scan for her expertise, and it's really revolutionised, I think, how we manage prostate cancer. Yeah.
Thanks, Raji, because I didn't realise that.
Multiple levels as well, just not at the diagnostic stage, on restaging after people have been through treatment to reassess what's actually happening in the circumstance, and it changes a lot as to what I do for radiotherapy in terms of direction and targeting ability. It's been a big player on that level.
Okay. So do you still need to have a biopsy? Or do you have a biopsy if you have this kind of scanning?
Yes, so MRI is something that people do routinely around the time of biopsy, and PSMA is something that you would do once the biopsy's happened.
Right.
At this stage, when you know you've got prostate cancer, you want to make sure that it's contained, that it's treatable with a treatment like a radical prostatectomy or what we call focal treatment. You don't need a more systemic treatment. And so, no, it definitely hasn't replaced biopsy.
Okay.
So I have to say on the biopsy now, it's traditional that we always do a biopsy to get a diagnosis. But having said that, I've had 3 patients actually, we've actually done definitive therapy now without having a biopsy because of scans such as Louise was mentioning, MRI scans now, and also the PSMA scan. So I think we may move to a phase where we do definitive therapy without biopsies, but at this stage we do require that for diagnosis.
I agree that we might eventually move to that in a subgroup of patients where they don't need to have the biopsy because it's very obvious exactly what the problem is, and we're hoping to do a trial in that in the next couple of years.
So we have a patient who has a cancer diagnosis and it comes back positive. What would be the next step for that patient? Would they see a surgeon? Would they see an oncologist? What would their journey be?
If someone presents with effectively localised or early stage disease, then the question of definitive or curative therapy comes into play, and they're an otherwise fit, relatively well man. They need to see both. As to the order, well, they obviously would have a biopsy up front to establish the diagnosis, like Raji Kooner and so on. But on the same level, they should see a radiation oncologist to get the full spectrum of what the options would be if they're otherwise entirely curable. Even if they're not, even if they're locally advanced, it's still a similar situation. But yes, they should see both players. And the question of a medical oncologist comes into the complexity as to risk, the risk features of presentation, as to whether they'd need anything more than that at a subsequent period or around the time of diagnosis.
Yeah, I just add that when we have someone with a diagnosis, we have quite an extensive discussion. And we discuss all the options, and they're offered, to see the radiation oncologist and oncologist. We encourage that. And certainly, we're very fortunate in this institution that we have multidisciplinary meetings. So when we have complex cases, we will present them, and we'll have everyone in a forum, just next door, and that's extremely beneficial. So I think it's good for patients to go through, the thought process and have every option given to them and the pros and cons of each option. And we try to engage them in the decision-making process. So it's it's not the old traditional form of surgery or medicine where you tell patients what to do. It's a sort of decision-making process that we do together. Mm-hmm. Yeah.
So talking about that decision-making process, what if they're having surgery, what are the surgery options that are available? What types of surgery might they have?
Yeah, so the surgery essentially is fairly basically removing the prostate gland, but the prostate's located in quite a deep, inaccessible area, so it's technically quite challenging to do. So the options are either to do it with open surgery, which is an incision, to do it with keyhole laparoscopy, which is doing it sort of freehand with your hand and looking at a TV screen, a bit like people have their gallbladders out. And then the third way is the robot-assisted technique, which is now, I guess, in most centres, the preferred technique because of advantages, certain advantages. And the main advantage is that just allows you to do the operation much more accurately and precisely. It's much safer. Usually in hospital for 48 hours. The blood loss is much less. In fact, out of the 1,200 cases I've done, we've had 0 blood transfusions, which is quite remarkable. And before, it used to be thought to be quite a very serious operation, and so it's been transformed really now. So I'd say in the United States, for example, 90% of all prostate cancer operations are done with robot assistance. So I think that the trend is now to do that. But again, we go through and explain all that to patients and the pros and cons of everything. But it's important to remember it's not a robot. It can't do anything by itself. It's just almost like a complicated pulley system where, the surgeon sits in a console. I just did a few cases today where you sit in a console and you look inside and you have little instruments inside the patient. You have gas in the abdomen, and as you move your hand controls, the instruments replicate your hand movements. And you get a 10 times magnification, a 3D view, because there's 2 cameras that marries the image together. So it's like an IMAX theatre vision that you get. And it's quite relaxing for the surgeon. You know, you can get up and go for a walk if you like, but you don't. But really, it's ergonomically, it's much better for the surgeon, and certainly for the patient, I think the outcomes are significantly better. But I think the important thing is to have the operation done very well rather than a particular technique. But yeah.
So speaking about that, I think some people here, I've heard of something called the nano knife, or the nano knife. Could you explain what that is and when that might be used? Someone?
Yeah, so nano knife is electrical therapy that's given, but it's a form of what we call focal therapy, where a decision is made only to treat part of the prostate. So the concept behind that is that prostate cancer may start from an index lesion, a primary lesion, and that maybe treating that primary lesion is sufficient for patients. I think at this stage, most people would say that's still somewhat experimental, and it really should be done in a trial basis, in the context of a clinical trial. And it's usually used in patients that have maybe a lower grade cancer, where there may be some indecision on whether you should treat it or not, or the patient particularly wants to have that form of therapy, but it's still being evaluated in terms of its efficacy. But there are various ways to do focal therapy, and Raj might tell us a bit about that.
Exactly, thank you. I mean, focal therapy is a bit of a topic of significant interest in the field over the last couple of years, worldwide and also here. It's been used for either relapse disease, people that have had prior treatment of the prostate from either radiotherapy or other forms of definitive therapy. Nanoknife is one, as we've said. The other option includes seed brachytherapy in a limited sense for a partial volume implantation, or other ultrasound-based treatments, what's called high-field, high-intensity focused ultrasound, but they're largely historical now, since we've seen more intermediate-term data come through in terms of symptoms and tolerances. But focal therapy as definitive therapy is the other area that's emerging on a trial basis. So we've put a number of patients through on that approach, on a protocol-driven basis. In other words, limiting volumes of the prostate that could potentially be treated as the only site of treatment volume to limit potential toxicity and side effects for the longer term. It's a concept, it's developing, it's yet to be formally established, but it seems promising at this early stage. And that can be done with, at this stage, the prospects of seed implantation to do that is reliable and reproducible.
So also is radiotherapy or chemo or chemo used in the treatments with surgery? Like what kind of therapy, non-surgical therapies, apart from the ones you've just mentioned?
Well, the main one, the obvious one, is radiotherapy.
Yep.
And radiotherapy comes in multiple facets and arms. If we're talking about curative treatment up front, you've got current state-of-the-art external beam radiotherapy with current sophisticated technology in terms of image capacity, imaging and reproducibility. You've got brachytherapy in terms of its various arms again, what's called high-dose rate brachytherapy, which is a temporary implantation, or permanent implantation, which is seed implantation of various sources. We use iodine-125 as a radioactive source in this country. There are numerous others we use in other countries in North America and in Europe. They're the main definitive options that you have. Chemotherapy is a more complex issue in the mix for upfront consideration. It's an emerging, well, it's more than emerging now. It's established in terms of higher risk patients, either upfront or in the adjuvant or post-treatment scenario, post-definitive therapy scenario. But yes, radiotherapy is the other main arm for curative intervention.
Okay. Now a question for you, Louise. There's a new therapy being trialled at St Vincent's to treat prostate cancer. So I understand it's a world first, so please don't undersell yourself. Can you explain what that is?
Yeah, it's not, I wouldn't call it it's a world first prospective trial, so we're really doing a very rigorous trial in it to see how effective it is. And essentially we have this PSMA, which we've been using for imaging that I mentioned before. And what we do is we've uncoupled the imaging part of it and we've clipped on a therapy part of it. So it's like a radioactive it targets the cell itself, it concentrates within the cancer cell, and it kills the cancer cell. Hopefully, very effectively, and that's what we're looking at the moment. So it's called lutetium PSMA, and it's a trial that St Vincent's is doing with Peter MacCallum Cancer Institute at the moment. We've injected a number of patients with it, and we're seeing some really good preliminary results. This is very much, though, not at the beginning of the journey of prostate cancer. It's the very few patients who end up at the other end where it's a problem, and they've had, hormones, and that has not worked, and they've had chemotherapy and that has not worked. So we're really doing it in the men who don't have many options left. And we're finding in about half of those men, we're getting a very good response.
Okay. You mentioned hormone therapy, and I know that, it's treated, it uses in prostate cancer treatment. Can you explain when you use hormone therapy and why you might choose this over another form of treatment?
I might answer that actually.
Yep.
Hormone therapy is really a fundamental part of the whole treatment process for prostate cancer in some capacity. More often than not, it's involved or advocated. Upfront use of hormone therapy is usually limited to people with high risk disease. We know for a fact, based on long-term data and randomised trials, the clinical trials that we base all our treatments on, that the addition of hormone therapy for at least 6 months, if not 18 months to 24 months, for high-risk disease, with, for example, radiotherapy, improves outcome, improves survival. There's a well-established documentation of that. Beyond that, hormone therapy is then reserved for people that are beyond definitive upfront therapy for salvage scenarios or relapse scenarios to control the overall whole body burden of disease. So it's an important consideration because prostate cancer, as most people would know, is testosterone driven. You have to be a man, you have to have a prostate, you need testosterone. And all those three things play together to increase risk. If a man lives long enough, they'll develop prostate cancer. If a man dies and they have their prostate cancer looked at on an autopsy, it's most likely to have early prostate cancer in it. But whether it affects someone during their lifetime is the question. It depends on the level of prostate cancer cell aggressiveness at the time.
Can I just say, with surgery, the studies have shown that the addition of hormones plus surgery doesn't give, in general, added benefit, but with radiation it does. So
right.
Just to say that it doesn't mean that everyone who has therapy for an active cancer has hormone therapy. It's a surgical treatment. We don't normally give hormone therapy as an adjunct, but as Raj was saying, it can either be given as an additional treatment for local disease, or it's given when patients have spread of disease elsewhere.
So talking about treatment, on average, how long would treatment last and what side effects can patients expect to have?
What treatment? We're talking about radiotherapy or what definitive therapy?
Yeah, those.
Well, if we're talking about definitive or what's called radical radiotherapy with the current techniques that I was alluding to before, a full course would take in the order of 8 weeks. It's sessional treatment once a day, 5 days a week, coming in as an outpatient for a period of block treatment of 8 weeks, Monday to Friday session, so to speak. It's all given over a period of 15, 20 minutes. It's in and out over that time. It's of little impact to the patient as they're going through. It becomes a second job for the man. The man can usually function completely well, support their normal commitments, social commitments, functional commitments, work commitments, whatever the case may be, more often than not. When it comes to the other forms of radiotherapy in terms of brachytherapy, it depends on which type we're talking about, but the high dose rate, or what's called HDR brachytherapy, has two forms, two components. There's the surgical component, which is the implantation of the hardware, and a 2-day admission, and there are a series of connections to my equipment where the treatment's actually delivered internally into the prostate gland. That's complex. There's a lot of staff involved, and it's a complex process beginning to end. For the patient, though, they're effectively an inpatient for 2 nights and 2.5 days. And that's followed by the external beam radiotherapy component to a slightly smaller dose, if you like, or lesser dose over 5 weeks on average. So that's still about 7 weeks to a way to go, but there's a gap in between the first stage and the second stage. Seed brachytherapy is a different story again. If we're talking about low-risk patients that have got localised disease, then seed brachytherapy is often used as a one-step procedure, a bit like surgery. The outcomes for case-to-case matched early stage localised prostate cancer for someone having an operation, a radical prostatectomy of whichever form, versus someone who's had seed implantation for curative intent, the outcomes after 10, 15 years are effectively the same in terms of PSA outcomes. The choice comes down to the patient, obviously, as to what they're prepared to go through and what they're prepared to accept for relative symptoms and toxicities. But the SEEK approach is a one-step procedure. Once that's done, after the work up to that stage, it's follow-up. Regular PSA monitoring and checks with a specialist as time goes on for a period of at least 10 years. There are other variations to the SEED theme, again, a bit like what the HDR process that I mentioned also has. There's various ways to combine the SEED implantation process with external beam as well as an alternate option, which has been around for a while. But that's becoming more popular again in the medical community. Yeah.
Thank you. We might just talk for a little while now about other prostate-related problems and side effects. I know that with my dad, he was very worried about side effects such as incontinence and erectile dysfunction following surgery or therapy. These days, how likely is that, and how is that managed?
So,
question for me.
Sorry. Yeah. So I think you're talking about surgically. So look, a lot of the side effects from surgery depend on the extent of the disease the patient has initially. So if a patient has prostate cancer, which is we think is confined purely to the prostate and it's unlikely to have pushed outside, then these days, particularly with the robot-assisted approach, with the 10 times magnification, etc., we can peel off the nerves for erectile function. And patients, if they have normal function preoperatively, have a good chance, probably above 75% chance, of maintaining erectile function at 12 months. But often patients will be detected a bit later, and we have to go a little bit wider and sacrifice some of those supporting tissues like the nerves there, and hence the outcomes from that point of view will be, is lower. As regards incontinence, the risk of severe incontinence is about 1 to 2%. And partial incontinence requiring pads on an ongoing basis, we quote about 2 to 3%. But patients do have leakage afterwards. It takes on average about 10 weeks to come good. But I think the really important thing to remember is that, these two issues, if patients have them, can be addressed. So we have a sexual rehabilitation program with our clinical nurse. So if you have trouble with erectile function, there's tablets, obviously like Viagra and Cialis. There's vacuum pump devices, there's penile injection therapy, which works exceptionally well, and there's actually penile implants that people do. It's got a 94% satisfaction rate, and so as long as we address those issues with patients, patients need to know that they could have a very fulfilling personal life with their partners. And then with the incontinence, there's now a variety of treatments available. There's some slings, a synthetic sling that get pushed that we insert called an advanced sling that provides a bit of support, and for mild incontinence that tends to fix that. There's a new procedure that I've been doing here called the Atoms procedure, which is an adjustable cushion that's all internal, there's nothing on the outside, and you can inject saline in there to increase the pressure, and that decreases incontinence. And then for patients that sometimes have severe cases, severe incontinence, we can use what's called an artificial sphincter, which is like a tube, almost like in a bit of a tyre that goes through, and where they pass urine, that's inflated all the time, and they have a little pump just in the scrotal area, which is only very small, so everything's concealed, and they just squeeze it 1, 2, 3 times, the air comes out and they pass urine, and that transforms their lives. So I think the important thing to remember is that we've had lots of advances. We decrease that incidence,
there's obviously been enormous advances.
Yeah.
And Raj,
just to add to that, from a non-surgical perspective, the patients that have definitive radiotherapy in which of the forms I've mentioned, there's a slightly different spectrum of side effects that are typically predictable to a certain degree. Incontinence per se isn't an issue in terms of subsequent sequelae from definitive radiotherapy, but you get inflammatory symptoms in the waterworks. There's predictable low-grade urinary irritability, and also to an extent small bowel softening in frequency, particularly with the external beam 8-week course of therapy. But it's very subtle. and it's gradual in onset, peaks by the end and quickly reduces, usually within the 2-week frame after treatment's completed. There used to be historical problems with the older techniques and methods we used to use in terms of the planning and treatment reproduction process that had higher risks of rectal dysfunction in terms of mucousy residue or even bleeding on occasion, up to about 6 to 7% of patients long term. But with the current methods, with the technology that we've got for image mapping and for treatment delivery, that risk is down to less than 2%. Erectile dysfunction, no one will get impotent with radiotherapy, but the vascular issues long term from flow in particular can be affected. So I overestimate that 1 in 3 or 1 in 4 men will have some reduction in your ability to sustain an erection long term. And that's usually rectifiable with the current tablets that are available nowadays. Fatigue is the other issue long term. Not long term, but I mean during and in the subsequent weeks after therapy, non-specifically from the radiation treatment.
Okay. Even without the prostate cancer, enlarged prostates are quite a common problem, a common condition that can cause a range of symptoms. Can you explain the types of treatments that are available for enlarged prostates?
Yeah,
Raji.
That'll be my area.
That'll be your area? Thanks, Raji.
So I think it's important to remember that there's been a number of advances. So when we have someone with lower urinary tract symptoms, and it's a very common thing, it's much more common than prostate cancer. As people get older, the prostate enlarges, it sort of affects the flow of urine and causes a lot of additional symptoms such as getting up at night, urgency, frequency. So we base it on 2 things. We basically work it on the bothersomness of those symptoms for the patient. How is it affecting their quality of life? Can they not go to movies? They restrict it can affect their lives quite dramatically, and sometimes people won't go out because of these symptoms. So if that's quite significant, then we will initiate therapy. The other thing is we check whether the bladder is emptying properly with an ultrasound usually, and if the bladder's not emptying, that's a sign that the bladder may be sustaining some damage. So that might be another reason why we would initiate therapy. We initially look at a medical therapy, and there's a variety of drugs. There's some drugs that relax the opening of the bladder and allow you to pass urine, and there's some drugs that shrink the prostate and improve outcomes. But they're generally used for milder cases. And then as we move along, there's a couple of new treatments. There's a new treatment that that I've been performing called a Urolift, which is a endoscopic treatment where we put sutures inside the prostate and pull the prostate out to allow the patient to pass urine. That's a day case or an overnight case. And the main benefit from that is there's no sexual dysfunction with that treatment, but it's suitable for only certain patients. Having said that, probably about 60% of patients would qualify for that. And then the definitive treatment is usually a prostate resection. The traditional methods are transurethral resection of the prostate. Most people know it as a rebore. And we create a tunnel through the prostate, but the standard method uses electrocautery. What we've been doing here at St Vincent's is using a laser called a holmium laser, and we've been very fortunate. I think the Curran Foundation actually donated the laser that we had that I've used most of the cases on, and the laser actually cuts and seals, and it gives much better outcomes than the standard method. So I've done over about 2,000 of those, and we've, again, not had any blood transfusions. It uses saline for irrigation, because as you do the operation, you've got to run fluid, and saline's the same thing you put in a drip, so when it absorbs, it doesn't cause problems, whereas the electrocautery fluid is glycine, and that absorbs and can cause problems. So you have much less bleeding and quicker recovery. So there's medical therapy, there's more minimally invasive therapy, which could be the Urolift, and then there's surgery, which is either a TURP, transurethral section, or a laser surgery.
Okay. So we'll now just deal with an area which affects women as well as men, which are kidney stones. We're just going to throw kidney stones in the mix. So they cause severe pain when urinating and pain through the back and side. So it could be men could come thinking they had a prostate problem, but it's actually a kidney stone problem. Would that be correct?
It can if they've got a kidney stone that's move. So the kidneys are up the top, the bladder's down the bottom, prostate's underneath, and stones form in the kidney. And generally they cause symptoms when they drop down into this tube, which is called the ureter. It's a very thin tube. So it's a very common thing. At least 10% of people will get a kidney stone attack at some stage. So there'll be someone out there who will, or has. Yeah, so it causes a obstruction. Generally you get pain in the loin area. But if the stone comes down the bottom towards the bladder, then you can have symptoms similar to prostate problems,
right, yeah.
But it tends to be more acute. But these days, again, with kidney stones, there's a variety of treatments, but you can have shockwave treatment from outside, where you just lie down and have external beam shockwave treatment, which can fragment the stone. Or generally these days, we tend to do minimally invasive surgery, where we will go up through the urethra, through the front passage. And it's quite remarkable. We can go all the way up to the kidney with these thin tubes, and we use a laser, similar laser to the prostate laser, but at different settings, and it fragments the stone or turns it into dust. In fact, the new laser that we got last year, the energy is so high that we can have a very high repetition rate with a low power, and so it basically turns the stone into dust or sand. So we can now treat very large stones in that minimally invasive way. So, there's lots of advances in that area as well.
So I think the lesson to be learned is that if you have any kind of pain, don't assume it's kidney stones, because it might be prostate. Don't assume it's prostate. It might be kidney. Have it checked out. Go to your doctor.
Yeah, I think everyone really...
Yeah, except that the prostate cancer situation doesn't cause pain. Prostate cancer per se.
Difficulty urinating.
Yeah,
it
that's
could
right.
be kidney
Changes in
stones.
urinary symptoms.
Yeah, sorry.
And renal stone pain or kidney pain is often exquisite. It's often, it'll buckle a man over, or a woman over for that matter. It can be quite severe and present yourself to emergency because of it.
Okay. So finally, obviously cancer and the conditions around it are quite distressing, but not only for the patient but for the family as well. What do family and loved ones, where do they go? Who do they turn to? Who do they talk about? Are there specific groups or counselling available for people going through this treatment?
Well, yeah, I mean,
I'll let you...
No, there's prostate cancer support groups, Prostate Cancer Foundation. There are support groups within the campus here as well, which are very good, accessible for patients and family. And they have lectures and talks during the course of the year similar to this, which are on general aspects pre and post therapy and in support group roles for carers. So the answer is yes.
Very, very active, aren't they?
Yeah.
The Prostate Cancer Foundation in that role.
Yeah, I think
So
the
there's
general...
plenty out there for people to...
Yeah, that's right.
The general perception's changed now. I think before people didn't talk about this issue, and it's great everyone's come here and happy to discuss this, whereas I think maybe in your father's generation people never talked about it, and people always say that was now... And so invariably in our practice we have a lot of patients who are very generous with their time. They're very happy to speak to patients, so we often will give the patient who's had a diagnosis, try to match them up with some people to speak to. But then, as Raj was saying, there's the prostate cancer support groups, there's counsellors available through the Garvin and the Kinghorn Centre, so there's lots of support that's available for patients. And actually, on that there's also, there's a realisation that the partner also needs a lot of support now. So I think people are becoming aware of the importance of all that in the last few years.
That is a big component of it as well. I mean, that's often not a neglected component, but an area that's not supported anywhere near as it needs to be more often than not. Like someone, particularly any healthy man that's been diagnosed with a life-changing condition, which is curable, but it's a traumatic process, and the partner is often isolated in their own indirect way while the patient or the man is being nestled through the process. They're often put to the side and they will suffer. They need that support just the same. And these groups do offer that ability.
Good. And I'm sure they're easy to find online or through your doctor. All right, well, that's really all we have time for today. If you do want more information, as I said, Raji has a website, prostatesurgery.com.au, which has a lot of information. And I would also just like to say that, St Vincent's public hospital does need support, the foundation does support St Vincent's and enable St Vincent's to continue doing groundbreaking clinical research, as Louise is doing, and new treatments. So if you're interested in supporting St Vincent's, either now or indeed after your lifetime through a gift in your will, then please speak to me or my colleagues who are here today. They'll be there on the way out, or you can visit the St Vincent's Foundation site, www.supportstvincents.com.au. Please thank again our panel, Raji, Louise and Raj. And thank you very much for coming this evening.